We begin this first session with a question that the COVID-19 pandemic forced every government globally to answer, usually under the worst possible conditions. Are we ready to face a pandemic? And the honest answer for most of the world was not enough. This session will bring together some of the sharpest minds on this question, from global organizations, national institutes, to the front lines of disaster risk and to the cutting edge of science. Moderating this session is Dr. Rohini Omkar Prasad, a public health physician and policy specialist with over 15 years of experience across the Asia Pacific. As Regional Director for Southeast Asia at Access Health International, she leads multi country research and advisory work on health systems, digital health, and chronic disease, partnering with governments and multilateral organizations across the region. A fellow of the Royal Society for Public Health with a Harvard MPH, she brings clinical grounding and policy depth to the region's most pressing health challenges. With that, I invite Rohini to please take the floor.
Thank you, Stuti. Good morning, everybody. It gives me, I'm sorry. It gives me great pleasure to moderate the first thematic session for the day, Prevention, Preparedness, Response, and Recovery for Public Health Emergencies and Crises. As Stuti just mentioned, the COVID-19 pandemic exposed critical gaps in public health systems worldwide. And while global agreements like the WHO Pandemic Agreement have created momentum, countries now face the even more critical task, the harder work of implementation. Translating these many policy commitments into functional governance, building infrastructure that withstands crisis, and ensuring communities are active participants. Even in our inaugural plenary, several of our speakers touched on the topics that we're going to be talking about today in a little more depth. The session examines the practical realities of operationalizing prevention, preparedness, recovery, and response systems. We bring together expertise spanning governance, architecture, environmental surveillance, operational response, disaster resilient infrastructure, and One Health implementation. We hope to move beyond just identifying gaps to talking about practical pathways forward for strengthening health systems resilience. Our first speaker for the day, joining us virtually, is Dr. Sohail Sekat, Senior Advisor, Primary Healthcare and Lead Health Systems Resilience and Essential Public Health Functions, WHO. Dr. Sekat is joining us virtually from WHO headquarters, where for 20 years he has been at the forefront of health systems resilience, leading the essential public health functions portfolio. He has conducted joint external evaluations across multiple countries and leads global discussions on what it actually takes to build prepared health systems. Let's welcome Dr. Sekat.
Doctor. Okay, I believe you can see my slides now. I don't think you can see me, but Dr. Rohini kindly projected, I think, one of my picture, and apologies that I couldn't able to join you in person. But this is an extraordinary convening that I really cherish from WHO, and with my career in WHO for 11 years, I think we really applauding, I think, the work you do, I think, on this type of complex topic, which is not very transactional, I think, which is something trying to secure sustainability in the investment in health systems. So, colleagues, this is one of the slides I presented also before to this type of gathering. I think is a time of polycrisis that we are in now. We came out of from COVID-19 with a 7 million direct mortality, with additional 14 to 17 million was excess mortality. It was basically based on a modeling data, given that health systems in countries of all income groups, whether countries in Asia or countries in Africa or countries in Europe or countries in North America, health information system was collapsed in almost every countries. So due to that context, we had to come up with a modeling for this excess mortality calculations of between 14 to 17 million. So now the question is how we are going to address all of these crises. I think due to the economic constraint, due to the realities in many countries, we cannot look at these issues in isolation. We need to look at those issues in a more collective, more integrated way, diversifying the role of health workers, diversifying the role of health information system, diversifying the service delivery platform so that we can have a better impact of the investment and limited capacity that we have. So in this context, I think two things is extremely important. I think Dr. Ruhini and previous speakers, I think, kept referring to one, we need to bring that public health dimension, I think, to better bridge between core health sector and the allied sector, given that some of these issues are, are not direct responsibility of the Ministry of Health. And second aspect, we need to better strengthen the public health role of primary care by building resilience at the frontline health ecosystem. And I think, colleagues, this is another is a synthesis of global burden of 292 causes of death in 204 countries and territories. I think this concept of emergency, I think, is also changing based on geography and epidemiological shift that we are seeing now. And if you look at this figure in a summary, I think this concept of emergency, I think, for example, in Europe, countries in North America, countries in some countries in the East, I think has become non-communicable disease. And then in many countries in the small island developing states, I think is the climate change. And then if you still look at some of the countries in sub-Saharan Africa, is a climate change and communicable disease. So we need to, as a public health community, I think we also need to be very adaptive in terms of our capacity and preparedness to tackle this crisis in a proportionate way. And this is another picture. I think we do not need to introduce it. I think if you look at the media, I think what is happening now, I think is quite unfortunate. I think not very far from where you are located. I think countries that are plugged into protracted conflict with a very, very fragile health systems. And then if you couple it with climate change vulnerability, unfortunately, we are, as a global community, not in a very, very good shape. And this is very, very important, I think, in terms of preparedness, universal health coverage, health security. These are all interlinked here. For example, if the population displaced do not have access to services, do not have access to safe medicine, do not have access to the immunization, that means the protection, the resilience that we are perceived to achieve for mainstream population is not is not a sustainable one. Similarly, no countries can achieve their universal health coverage or sustainable development goal if their population continue to suffer from the impact of emergencies. So this national health security and global health security, I think, are completely interdependent on service coverage for universal health coverage. But unfortunately, I think this is another picture, I think, illustrating the fragmentations, the way different entries are happening at country level health system. For example, I think I presented that figure about countries under fragility, conflict, and violence affected. There are billions of dollars on humanitarian response. Similarly, there is an effort on IHR capacity development, global health security agenda, and also there are efforts for particle disease and life course specific program and traditional health systems are strengthening. And majority of this investment, as you know, are very, very transactional, very, very reactive, and also short duration, so that there is a often um, a, a missed opportunity, I think, to support the baseline health systems capacity development. And it's still happening, unfortunately, globally because of the lack of integration, lack of leadership from the national level. So the work that we also do from WHO headquarters, I think, focusing on resilience, I think, with a better addressing the public health aspect. Uh, so post Ebola in 2014-15 and post EBD in 2020-2021, we tried to look at the essential public health function and also its relationship with health systems resilience. And for the first time in WHO, we came up with a unified list of essential public health functions. And within that 12 functions that we came out by looking at global experience as well as the various lists that are available in public domain, I think there are two types of public health function that we identified. I think four service delivery oriented functions and eight enabling function. I think the beauty of this work is that it brings public health in one place, at least conceptually. Second, it helped us to avoid some of the blind spot. I think is very, very important. I think even in country like India or in other South Asian countries, we know that people who are marginalized, people who had comorbidity, and people who are socioeconomically deprived, unfortunately, they affected the most. So by applying the public health approach, I think in health systems are strengthening and also better bridging with the allied sector, I think we can make sure that within our society, within our population, those that are hard to reach, they are also be better protected. Secondly, is that the people who are healthy, who are enjoying better quality of life, if there is a crisis happen, they are likely to be better safe. So there is a huge body of work that we led from WHO. And within that 12 function, I think the one you could see is very important is about the stewardship for public health. And it has to be done during routine context. So we as a public health community often talk about what is the governance aspect, what is the conceptual definition of governance. And for the first time within WHO, we looked at that issues and we came up with an operational definition for governance for public health. So let me, you could see in the screen what it should entail. I think this right refers to process structure and mechanisms for decision making and oversight to guide and coordinate, and then most importantly, to ensure accountability regarding collective efforts of all stakeholders within a designated context. I think this definition, I think, is extremely important when we try to bring intersectorality in operation. And this definition, I think it also talks about mandate, legal authority, resource stewardship, and also operational and scientific independence in the context of public health. And it's become more important when the country enters into a crisis. So now global context, I think in line with the focus of your discussion. So this is the landscape. I think depending on the nature and a scope of crisis, this is the range of stakeholders at global domain that you can see. World Health Organization, we one of them. There are many regional bodies now like Africa CDC, European Center for Disease Control, Gulf CDC, European Union, and you also have a number of political platform, I think led by India, and India also part of some of those global platform. Similarly, I think depending on nature and the scope of the event, there is a Ministries of Health as well as the central government. Other UN agencies are also there, like UNICEF, like World Food Program, and then there are many other global health initiatives like Gavi, Global Fund. And then also within a national context, there are public health institutes or Center for Disease Control. And also more importantly, we have in every country, there is an NGOs and private and philanthropy sectors. So we need to be mindful that depending on the scope of the event is a very, very global system for coordination and response involving many, many stakeholders. And then if you look at a country, I think you can also relate whether you are from India or from another parts of the world. Even within country landscape is again very, very multi-sectoral. There are many, many actors. Some are directly within the responsibility of the Ministries of Health, like Center for Disease Control or Public Health Institute, the authorities responsible for healthcare service delivery, and then subnational authority. Then if you go outside of Ministries of Health, there are again multiple sectors, from food to the environment, to the transport, to the animal, to the environmental public health, to the social care. So we need to be mindful that when we talk about the governance, we need to think about the landscape that you need to work with, I think, to sustain and ensure the right governance for managing a public health crisis, as well as for managing public health in a routine context, which is more important. And this is another landscape that we came across. I think is a synthesis of the how the architecture for public health is is currently in operation in many countries. For example, we often look at the CDC or National Public Health Institute, but we often do not look at how that institute is operating within a national landscape. So there are basically four types of setup in globally. I think there are National Public Health Institute as a semi-autonomous or autonomous, but ultimately dependent on Ministries of Health, and then there is a allied sector. Then there are countries like now in United Kingdom, National Public Health Institute, which they call Health Security Agency, became executive agency. That means almost become part of the government. And then there are countries where the Ministry of Health undertake the public health responsibility, like Qatar, like Thailand, where there is no designated National Public Health Institute, but the ministry is directly take up that responsibility. And then there are also countries where interministerial setup govern the public health affairs. So the message that I want to convey here is that there is no single mechanism or setup that can countries say that is a right one. I think so is we need to look at the overall landscape and how different components and actors are coming together in their own jurisdictions. So just a summary, what about the current challenges in public health governance from global to the national level? First one, there is no unified approach. Second, most importantly, whether it's a Ministry of Health or National Public Health Institute, currently, I think the mandate is very, very limited. And then the third and the most important one, when we try to define the scope of public health, I think the is not always fall under the authority of the Ministry of Health, is very much distributed and dispersed across various line ministries. And current approach to governance is very, very silo and reactive. And intersectoral accountability is often obscure. I think there are some good mechanisms, but there is no mechanism that can be considered as generically applicable. So Rohini kindly mentioned about what we are happening, I think, at the global level. So we succeeded on the pandemic agreement. I think the purpose is to better understand and address the lessons that we learned during COVID-19. For example, the issues about the supply system, equitable access to medicines and vaccines, and the shortage in the workforce. So these are the things that are came out in the agreement for pandemic that was signed up last year, but is still needs ratification and entry into force at national level. Side by side, there is an amendment to the International Health Regulations 2005. And if you could see the some of the highlights on the right hand side, first one is a new pandemic emergency alert level, I think, to better coordinate the global response mechanism. Second most important one, in the past, we used to identify one authority. It can be a Ministry of Health focal point as a IHR focal point, but now the push is about is a more as an authority, as a mechanism to coordinate at national level rather than a specific institution as a focal point. So I think that is another major lessons that we learn from COVID-19. And then the third, another important one, as we had seen during COVID-19, the inequality became very, very profound from global to the country level. Now, under Article 44, we are asking about sustainable financing, not for developing countries. I think is again showing the interdependence and solidarity that we need to bring between the countries. So, colleagues, I think I'm not going to take long. So there is a huge reform agenda happening within WHO and UN setup. We call it a UN 80, UN 80. And then under pandemic agreement and IHR amendment, we are expecting that there can be a better coordination. And then there is a Lusaka agenda, as you know, one plan, one budget, one financing, one M&E. I think that movement is also happening. And there is a proper shift for coordination and support and financing between countries in different income groups, as well as countries to better allocate domestic financing. And then more importantly, there is a push for addressing the role of primary health care in the delivery of public health and to have better health systems resilience. And we as a team from headquarters, for the first time, we came up with a framework for public health governance. Within that framework, there are three components, as you could see. One is the core component, second is the enabler, and key principle. So the objective here is to respect the country's own institutional setup, but to better understand whether that setup has these attributes, whether the setup, whether it's the Ministry of Health is providing the responsibility for public health, or is it a Center for Disease Control or National Public Health Institute. They need to cross-check whether they have the right core component. What are strategy and policy development, the ability to force partnership, legal authority to bring the accountability of the other sector, and is a stewardship for resource mobilization and monitoring and evaluation. And they also need to check whether they have the right political support, financing, legislation, and institutional structure from the central government. And the key principle should need to be their integration, comprehensiveness, and shared responsibility. And colleagues, on the right-hand side, I put intentionally all four service domains of public health, from protection to promotion to prevention to public health emergency management. I think it's very important. We cannot have the governance only focusing on pandemic preparedness. We need to found the requirement for governance in the routine health systems as strengthening, bringing other parties in place. Otherwise, it's not going to be a sustainable one. I think the effort that we had to put in place during COVID-19 is an unaffordable one. We need to go away from that type of reactive governance and investment to routine health systems strengthening. And we also came up with a checklist that every countries can use to benchmark where they are now in terms of the governance for public health. I mean, is a very flexible framework that we came up with. For example, whether the country has got the Public Health Act, whether it recognized a mechanism, whether it has got the sufficient budget line for public health. So a very easy to apply checklist for countries to to benchmark their governance for public health, whether it's for EPR or is it for health promotion or is it for some of the other pressing public health issues. That this generic framework can be applicable based on country's context. And these are some of the list of publications I think that we have, and many of them I think are also benefited from our joint work discussions with Dr. Reddy and his team and my friend and colleague Maulik and many of you that we have been working over last 5, 6 years very closely. And I was very pleased to see that one of the previous speakers also kindly referred to one of our publications from WHO headquartered in Geneva. So thank you very much, Dr. Rohini and colleagues. Back to you all. And thank you for your cooperations and partnership with WHO level. I also saw Dr. Manoj also kindly spoke, I think, before at the opening session. Thank you very much. Sorry that my camera is not working this morning. I don't know. I connected from home. Back to you all.
Thank you, Dr. Sekat. Apologies that you were kept waiting, but we are really appreciative that you were able to join us, even though it was very early in the morning for you. You have set the stage for us to keep going with our discussions today. Next, we will have a series of presentations, and once the presentations are completed, I will invite all the speakers back on stage for the panel discussion. Up next, we have Dr. Rakesh Mishra, Director, Tata Institute for Genetics and Society. Dr. Mishra was formerly the director of CCMB, and he has led India's genomic surveillance during the COVID-19 pandemic. His research now focuses on genomics, developmental biology, and infectious diseases. He pioneers environmental surveillance, wastewater monitoring that tracks diseases before they reach clinics, building the institutional foundations to make this into permanent public health infrastructure. Welcome, Dr. Mishra.
Okay, there. Thank you, Dr. Rohini, for the introduction. And thank you, Dr. Reddy, for organizing this very important event. We come and exchange notes and get motivated by various discussions. So what I'm going to tell in next 10, 12 minutes is how we have been able to now scale what we began during COVID time with the help of many government agencies and collaborations to bring the surveillance into the closer to the national context. So as I just going to take you through like a journey, like a story. We began when the COVID came very early. We did actually one of the first surveillance from the sewage treatment plants from Hyderabad, and we found that actually the cases were 20 times more than what was clinically reported. And it turns out that when later we did the zero surveillance, that this was really exact number. So that gave us confidence that wastewater is the truth, and then we should go and focus on this. So we actually extended the analysis to, first one was done with sewage treatment plants. Then we switched to open drainage, because most of the country is open drainage. There is not much of a sewage treatment plant. Even bigger cities, it's only partly sewage treatment plants. Open drainage is a very important system. And then we standardize how to do this surveillance, and we continue doing this till now for the COVID 19, that is SARS-CoV-2. in Bangalore using STPs, and in Hyderabad using 19 open drainage system, and here around 25 STPs. And we keep monitoring when the silent waves keep coming and going, though clinical cases, because we are all vaccinated and immune to it. So, and this, when we had began this, then uh, motivated by the Rockefeller Foundation funding and willingness of many organizations to work together, we set up this alliance called UPSI, where many major institutions got together to doing surveillance, developing diagnostics. It was really like an emergency response during the pandemic. And in this uh, uh, Rockefeller Foundation driven initiative, we started with 4 city clusters: Hyderabad, Bangalore, Pune, and Delhi. And then there are many other stakeholders, many other labs, clinical partners, industry partners. They played important role in developing the diagnostic, which you just heard in previous session, and working on the policy and involvement of government and the municipal corporation. We set up the routine of how to do the disease surveillance in these cities, and how to use it for epidemiology. And later I will tell how we switch to AMR and other microbes. And in parallel, we also kept doing skilling or training the people in urban, rural settings for diagnostics and point of care testing. And indigenization was very important. Otherwise, all is useless if you don't have reagents, or they are very expensive. So that was very important. And equally important was the knowledge transmission and outreach, which uh, 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 we took very seriously. And we organized series of meetings with very important stakeholders, multiple. This is a picture of one of this meeting, which happened actually here in this building. And we brought the stakeholders, discussed with them, took whatever was the advised, and we were able to impress the all the policymakers and decision makers that surveillance is important thing, environmental surveillance is important thing for us to integrate in our system. We also came up with the protocols and SOPs, and all these are the list of protocols that are freely available in the website. This was developed, refined, almost every aspect of environmental surveillance. We also made a national guideline draft, which we gave to NCDC, and that's being discussed. And NCDC is quite on the board with this, because they are the key agencies which can use this data and take the policy decision, work with the government. And so this was largely RT-PCR based testing. Then when we got really the feel that environmental surveillance is so important for many aspects of disease and pandemics, we switched to what we call as genomic approach using metagenomic technologies. You can this works because each one of us shed millions and millions of cells every day and contribute our DNA to the wastewater, and so do all other microbes and plants. So actually, if you collect water and do now the whole genome, whole uh, microbiome, genetic material, and do the sequencing, you can actually do the entire ecosystem, all the biodiversity of the place. Is so and this the data that is generated using the metagenomic is applicable in medicine, in agriculture, environmental sciences, and it's even more important because the lots of urbanization, movement of and migrations, decreasing of biodiversity, which disturbs the process, human wildlife contacts, which I mean to say that these things are so fast that many things happen beyond our imaginations. And unless we do the unbiased analysis of the samples using the metagenomic approach, we will not know what is happening, or we will know only much later when the damage is done. So one of the things we have used this technology is in the AMR. AMR is, as you know, is a really one health problem, because lots of factors contribute to it: interaction with the environment, misuse of antibiotics, and excess use, and then assembly of all these things in one common place. So This requires really interaction and collaboration of multiple agencies. It requires extensive surveillance and monitoring, and it's one health which is a global issue, and they need local participation because that is where the information comes from. And the way we did this was using again the open drainage system and collecting genetic material from there, and not going through RT-PCR for known pathogen, but doing the metagenomic analysis and then searching for the uh, uh, AMR signatures in them. And over I mean, this is one flash shot of this, that the kinds of things. This is again in Hyderabad, and what you see is the along the city in context of various medical hospitals. We did these collections, and this shows. I'll show you a little more. So this shows that what all we were able to figure out from this. So this metagenome is only looked for AMR. So we can ask which antimicrobial resistant genes are seen, which drug has gained maximum resistance, and which resistance mechanism is operating. And you can see, although there is a lot of similarity in most of them in the pattern, you can see the second last looks something which stands out. This location called Golnaka. In all the pictures, it was different. And when you go and back and see, this is just downstream of the major slaughterhouse. So slaughterhouse contributing different kind of genes in the system. So we discovered it later. So it was very interesting that this is really an unbiased and gives you the real picture of what is happening. When all this were achieved, then we started interacting with ICMR, and since then ICMR has been our really a big partner and collaborator and funder in all capacity, and we were very close together. How we started was that you just heard about the VRDL, Virus Research and Diagnostic Laboratories. They are across the country. Now we have a program with ICMR where we collect the wastewater uh, from the hospital settings of the VRDLs. We do on the one hand, metagenomics and make what are the genes that need to be looked at for the AMR, and make the indigenized kits, which can then be given back to VRDLs for doing the surveillance once in 2 weeks. And to achieve this, first we had to train. So we have trained now 57 VRDLs where the surveillance is now being done for over an year. We make protocols. We made several rounds of trainings, and about 110 permanent staff were trained who are now generating data. And this is what is the distribution across the country now. AMR is being monitored closely. And to do this, with the help of our collaborators and ICMR, we develop not only the SOP, how exactly they have to do it, sample collection kit, how from very basic to how to collect the sample, isolation of DNA and RNA from that particular kit, and also we made a customizable panel for 20 RGDs, all indigenized, so that and this based on the metagenomic data, we can keep changing this, and we will eventually we will have maybe different kits for different regions in the country, and these are all done in very affordable manner. Whole thing can be done in 600-700 rupees a test, so that is really affordable. It just costs nothing. And this is the result of about 1 year of analysis from VRDL, what kind of patterns is emerging. There's one kind of pattern, there's another kind of pattern, and so on. So we see the 3-4 different kinds of patterns. They are different parts of the country, and this data is being analyzed. And this is the metagenomic data. You can see that what are the relevant pathogens in different we are looking at 22 VRDL data here. What are the top 20 prevalent and so on. So you get lots of information which then can be used for a variety of purposes, including designing effective kits. So what I explained to you, I had to go fast because we don't have much time, that we in this process past several past 4-5 years sampling strategy, processing, and pathogen and genome surveillance. All this was done with the help of ICMR, NCDC, National One Health Mission, and so on, has now gone to almost entire country. And this is the story. So from 4 city cluster, we came to AMR, which I just described to you, how we are doing in 57 centers, which has a hospital wastewater as a sample. We have just begun a few months back a metagenome approach for syndromic surveillance, where the clinical samples are the starting material. And then we are just starting a national level metagenomic and disease surveillance program, again with the help of National One Health Mission, WHO, ICMR is fully funded by One Health Mission. And here we are using the community wastewater, which basically superimposes on the polio surveillance that is being done. Now this will be used for surveillance of the entire country, 100 locations spread all over the nation. So what started in Hyderabad, a small surveillance, has now reached at this point, and we are now preparing the blueprint of how this can be then expanded to the all India level, 1,000 locations, so we can have complete picture on a affordable and useful manner. There will be challenges where we'll need to discuss that where we should collect the sample when you are talking about the entire country. There are many places. How often we should do this? Once in a week, once in a month. What organisms you want to look? Metagenome is once in a while, but it can't be done on a regular basis. So you have to make choice, and which technology to use, and data sharing. Most important thing, that if data is not shared immediately, it's not really very useful. So we have to do a collective effort to make this happen in a way that public health outcomes are seen. And this is my last thing, that we also in this process learn what is One Health, how to quantify it. And we have, there are not much ways to do that. So we have developed now two different ways, and they are now really very robust. How to calculate One Health Index for the country. Now we are developing a web tool where you can go and feed the data and calculate the One Health Index of your city, or your village, or your state. And you can also make changes, that if you allocate more budget in this part or that part, how the One Health Index will change. So what is the better use of your resources? We have analyzed this on several 3 years of national budget and its impact on One Health Index calculation. I'm very excited that this is something which will be useful for policy making and public health management in the country at a very granular level. This was, as I said, was possible only because of large number of collaborations. Rockefeller in the beginning, early days, then National One Health Mission, ICMR are the real our partners. They are not only funders, they are partners, and many municipal corporations like Bangalore, Vijayawada, and of course NCDC partner in all these big program that is going on. Thank you very much for your attention. Uh, I'm 2 minutes late. Thank you. So we'll have question other thing later, right?
Thank you, Dr. Mishra. You really took me back to my childhood where I grew up in Hyderabad, and one of our field trips was to a sewage treatment plant. And it's really nice to see that really come home and see the impact of the kind of work that you're doing now. Up next, we have Dr. Pranay Varma. Dr. Varma is the Joint Director of the Integrated Disease Surveillance Program at the National Center for Disease Control and in charge of India's Public Health Emergency Operations Center. He leads India's real-time surveillance of 52 epidemic-prone diseases across billions of people and has deployed rapid response teams in several states during outbreaks, including the 2024 Nipah virus in Kerala. Welcome, Dr. Varma.
So good morning to everybody, and I would like to thank the organizers for inviting me to the session. Can I have the presentation? Okay.
Just a minute, everybody. Apologies for that.
Yes, thank you. So thank you very much. So I hope the presentation is visible now. Oh, thank you. So I will basically be touching upon the data and surveillance for crisis preparedness and response that we undertake at Integrated Disease Surveillance Program at the National Center for Disease Control. Now, this is going to be the outline of my presentation. So these are the main points that I will be covering over here about the program, the sources of data that we have in the program, the surveillance framework that we follow right now, how the outbreaks are being identified at the Integrated Disease Surveillance Program, what is the preparedness system that we have, and what are the response mechanisms that are in place right now. And there are some supplementary points that we will also discuss basically to touch upon and to emphasize the main points. Now, in the interest of audience who do not know about IDSP, so the link is over here. So the mission of the program is essentially the surveillance of epidemic-prone communicable diseases. And we do that to basically detect early warning signals so that timely public health responses can be initiated at different levels. So we have the units all the way up from district surveillance unit up to the national level, which is integrated at the NCDC, the National Center for Disease Control. And if I talk about the mandate of the program, I will say that there are 4 important mandates that we have. One is integration and decentralization of surveillance data. So basically, the data is decentralized as much as possible. So the more closer we go to the field, the better data we get. But it has also to be integrated at different levels so that a holistic picture and the overall response can be properly coordinated, and things make sense at different levels. Then the surveillance staff who are engaged at different levels, their training is an important component. So the training of the state surveillance officers, paramedical staff, the partner organizations who work with us, that is being undertaken. A lot of emphasis have been put in information communication technology so that the information that is being gathered at the field level, that is transmitted as soon as possible to the different levels, and it can be acted upon. So collation, compilation, analysis, and dissemination of data can be undertaken at different field levels at the national and subnational levels. And of course, there is strengthening of the public health labs. So the diseases that are being surveyed over here, their lab diagnosis is an important component. And our mandate was to have one public health lab in each of the district of the country. Now the IPHL concept has come up, the integrated public health labs. So much of the public health labs that we have are gradually being subsumed into the IPHL system itself. If I talk about the sources of data, there are reporting units that we have from Ayushman Arogya Mandir, which are earlier called as sub-centers, all the way up to the tertiary care facilities, up to the medical colleges. So in total, there are about more than 2 lakh reporting units. I will say about 2.5 lakhs in total. And the data is being reported in 3 forms, which is the S form, the suspected cases form, which is being reported by the ANMs from ARMS. Then there is a presumptive form, which is being reported by medical officers from any level, from PHC all the way up to the medical colleges. Then whenever the case is laboratory confirmed, it is reported in the L form, which is the laboratory confirmed form. And all the information basically flows into the integrated health information platform, which is the platform that is being on which the IDSP reporting is done. And that is a almost a real-time case-based reporting that happens in the IHIP platform. Now I will just briefly touch upon the key functionalities of the platform that we have. So one is the near real-time case-based reporting. So as soon as a patient is registered in the system and the data is being captured and it is being submitted, the information is available to all the levels from from the PSC, from where the patient is being registered, all the level up to the national level, so that the real-time reporting can be undertaken. All the cases are GIS mapped, so we have the heat maps and the spot maps. So in any outbreak, the first an epidemiologist is mostly concerned about where the cases are being bunched together, so that the action can be properly tailored, and they can know what is the source of that outbreak. So all the cases are GIS coded, and it is basically a granular reporting. So it is case wise reporting, so there is no aggregate reporting in most of the cases. And all the information basically then flows into the advanced dashboards that basically show the granular information at central, state, and district level. And it is possible to zoom in and zoom out of that level. So I can go to even to the to the block and at the facility level to see where the cases are being reported, and then I can basically come up to see at the national level what is the whole picture. For example, in case of if the cases of I have an unusual increase in the cases of chikungunya, and I suspect it to be coming from a particular area. So, for example, in the national level, I will see that there is perhaps a secular increase in the number of cases, but where the cases are coming from. So for that, it is possible for me to go to a particular state, a district, a sub district, and even to a particular area to see where the heat map is coming from. So to see that where the cases are there, which is basically forecasting in the national dashboard. And of course, to make sense of everything, there is integrated analytics. So there is basically for trend detection, threshold alerts, and statistical summaries, there is an advanced dashboard that is there, and it is possible to generate reports. You don't have to write any reports now, and it can be reports can be generated from the system, and it can be submitted to the policymakers. And one of the initiatives that we have undertaken right now is the community reporting tool, because we wanted the community to be involved in the reporting in the system. So you may also have heard in your locality that perhaps an unusual event has happened, a party has happened, and some people have gotten sick. So how do you report it if you want to report to the IDSP or to the government of India, how do you do that? So for that, we have basically rolled out the community reporting tool, which is outside of the landing page. So you do not need to log into the IHIP platform. Over that, you can basically open the form, and it is an OTB based verification. You can submit the information that you have at your level, and if you have taken any photographs, you have any clippings of the newspapers, you can basically include that, and you can submit it to the system. And basically, it is treated in the same way as alert that is being generated by a medical officer, for example, at a tertiary facility. So equivalence is given to alert at different levels, so that to make sure that real-time surveillance is undertaken at the ground level. Now, as in case of any surveillance system, we also have two-pillared approach, which is basically one is the indicator-based surveillance and the other is the event-based surveillance. So any surveillance system you can see in any part of the world, these are basically the two types of system that they will be having. So for indicator-based surveillance, we have about 55 conditions that are under surveillance in IHIP right now. And for all these conditions, there are some threshold that has been set. So whenever their threshold is breached, basically a health condition alert is generated, and that can be basically monitored and acted upon. Now, event-based surveillance is something that is unusual and unexpected. For example, we had 2 cases of Nipah that were reported in West Bengal earlier in this year. So that was something which is quite unexpected. We had Nipah cases in Kerala, but from West Bengal, we had never had Nipah in like 10 years. So how to capture those information? So that can be reported by health functionaries. For example, over here we had AIMS, local AIMS, which basically, they suspected it and they basically tested the samples and they had that diagnosis and they reported it to us. A big source of data for events is the media. So, in newspapers, you may have read every day that some event is being, is being published. That, for example, there are 50 people who have fallen sick in Bagpat, perhaps after a marriage party. So these kind of events are also captured in the system, and of course, through public, we have community reporting too. And all this basically generates an event alert compared to the health condition alert. And then basically that is basically also basically acted upon. An important part of event alert is the media scanning and verification tool that we have in our system. So that is for any kind of media alert that is being circulating in print and electronic media. So we have a real-time web crawler which keeps scanning the media and basically uh, shortlisting the events and then sending it to our dashboard. Now, data analysis these days is incomplete without talking about artificial intelligence. So this is one area where we have integrated it. So the tool basically keeps improving itself with each of the rejection or acceptance that we do, so that the basically the going forward the events are better streamlined, and we can actually increase the ambit of the surveillance also. And these events are scrutinized at IDSP because, in newspapers, we will have many events and many news articles, which are sometimes you will say that they are motivated by some people. It is, sometimes it is politically motivated, or sometimes it is just a rumor that you can say by, and it's very vague news that, for example, in UP, there are increasing number of fever cases. So this is something that is very vague, and there is no particular person whom I can send this event to basically act upon. So these are basically scrutinized, and something which we feel that that is to be acted upon, that is sent to the state and district, and then they act upon these alert. And that is active on all the days. So even on weekends we do it because we have incidences where a major event has happened in the weekends. So a lot of in many of the festivals there are community fairs that happen during the weekends, and during the national holidays. So we want to make sure that these events are captured as soon as possible. So this is the DSO dashboard that we have. This is the dummy dashboard. So the DSO can basically see the holistic picture. So district is basically the nerve center for us, where the intelligence of the whole district is being analyzed and it is acted upon. So he or she can see the event alert and the health condition alert that is popping up on his dashboard based on the data that is being fed by the system. And he or she can update the action. So they can sometimes they know that it's a rumor, so they can just discard it. If it discard, then it is basically goes out of the system. If they do decide that it has to be acted upon, then basically they can convert it into an outbreak, and then basically it settle down over here in the EWS outbreak summary dashboard, where you see that there are outbreaks that are basically ongoing in that district. So this is some outbreaks are basically it is ongoing, it is contained. There are some are under surveillance, some are completed, and all of them are basically you can basically see the real time picture what the teams are doing at the field level. That basically you can basically when you click on this action button, you can basically go and see do you have the epidemic intelligence from the field level itself over here in the dashboard. This is just a small snapshot that I have taken from our media scanning tool. So you can see that there is a event alert that was published in one of the media houses that Mukundpur, there was 40 people suffer from food poisoning. So you can see that basically it was captured. There is a translated summary. So the basically the bedrock is the open AI. So basically that is the one which does the AI based sorting of the events, and then there is the Google Translate, which is basically built into the system. So for example, we have our media scanning assistant who can read Hindi and English, but there is a lot of vernacular languages. For example, there is something that is important that is published in newspaper in Tamil Nadu, which we cannot read. So how do we understand it? So earlier it was not possible for us, but now Google Translate is basically built into the system. So it is giving me the translated summary over here. And I have the facility to see the original summary also. So for example, it is a Hindi news article. I want to see the original article. I can see that. And then basically I have published it. And then basically it has decided by the district that the investigation is actually required. They have indicated that investigation required, yes. They have basically initiated an outbreak response over here. So it is reported date when the outbreak was responded to. They are showing the number of cases. There are 47 cases were reported. There were no deaths. It is suspected food poisoning, and they still have to verify it. Perhaps they are waiting for the food lab test for the food samples to come to them, and then they are going to verify it. So all this information is available to us at different levels. Now, regarding outbreak identification, I think this is a fairly generic slide, but for us in particular, this is the way that we go about. So for example, signal generation is done using the threshold that we discussed. Event alert, something that is caught by from the media, then there is something that is reported by the community. And then basically it alert is triggered, and then basically that we have to decide whether it is to be acted upon, it has to be discarded. Once we decide that it is to be acted upon, we verify it. Then basically we classify it to at what level the response is required. Some responses are basically managed. Most of the responses are managed at the sub-district level itself. So local medical officers combined with some people from the the local level, some perhaps somebody from the CSU, some medicine specialist or microbiologist will move with him or her to the field, and they will basically work for the containment of the outbreak. If it's a major outbreak, then perhaps the district team will come into play. If it's an even bigger outbreak, then state RRT will be activated, the rapid response team. And if it is something that is to be acted upon at the national level, for example, we gave the example of Nipah outbreak in West Bengal, which is important for the country as a whole. Then the central level team moves around from Delhi or from the institute that is central level institute that is in Kolkata or in at any other city. Then basically they join the RRT response. And the RRT is mobilized. The Public Health Emergency Operations Center is basically activated also, and it is going to coordinate the whole response over there. Now coming to the preparedness framework that we follow in IDSP. So we have a multi-level strategy that we have. So there is continuous monitoring for timeliness and completeness. And this is something that is improving as the system is getting matured. Real-time surveillance we already talked about. So any alert is being generated on an almost real-time basis and is acted upon. One Health approach, the previous speaker basically also touched upon that. So most of the pathogens that we see right now, take for example COVID or Nipah or any of the emerging or re-emerging infections that we have seen in the last 5 to 6 years, most of them have come from the zoonotic sources. So the importance of One Health approach cannot be overemphasized. So here our partners are DHD, the Department of Animal Husbandry and Dairying, the wildlife, if there is perhaps a spillover from the wildlife side of the or from national forests, FSSAI, any kind of foodborne outbreaks. So basically there's a close coordination between the team members. And there is a cross-sectional training, sectoral training also to make sure that at least I am also aware of what kind of surveillance is being undertaken at the animal side. So when I move in the field with them, I am not blank. So tomorrow, if the media asks me that what is the surveillance that they are doing in animals, so it should not be that I should be telling that perhaps my colleague is going to give the answer to that. So that is something that is perhaps not acceptable when you are moving as part of a multidisciplinary team. So that is addressed through multi-sectoral trainings. Now, simulation exercises, one of the dignitaries also touched upon it in the morning sessions. So real-time simulation exercises are being undertaken right now. So we have Vishanu Yuddhabhyas, which are mock drills that are being undertaken in Rajasthan and MP, and it is planned in a few other states in the near future. How to ensure logistics and the systems are redundant. So we had mock drills. So after COVID, there was a lot of emphasis. We used to basically do mock drills and basically ask all the healthcare facilities to basically submit the information that they have regarding the PPEs, any kind of key medications that is there in stock, their stock position essentially. Now the system has slightly matured after the COVID. We have taken a lot of steps to ensure that we are ready to go in the field, and that has been basically an eye opener for us in more than one way. So, but still, we take periodic stock of the situation and to ensure that proper logistics are available when the field team actually goes into the field. Now, the response mechanism that we have is dictated by the condition in the question, like we discussed earlier. So one is the rapid response team that we have. So they basically undertake field investigation and outbreak control. It can be of the different levels from district, state, and national levels. So they go and basically assist the local functionaries in undertaking the containment efforts. Then we have something called as NGORT, which is National Joint Outbreak Response Team, which is initiated under One Health approach. So it is a multidisciplinary team which has some key agencies like MOHFW is usually the key agency through NCDC, ICMR, and FSSAI. Then we have clinicians, wildlife, DHD, and any other expert that we need to bring into this team. That if it is required, the notification usually goes through Ministry of Health, and it is notified to the corresponding ministry, and the experts are pulled into the team as and when required. Coordinated responses is to be undertaken in the field level. So, for example, the FSSAI expert will take the food sample and they will send it to their FSSAI labs. We will be taking the human samples. We will sending it to our labs. The wildlife experts will be sending the samples to their labs. So it is essentially a multi-sectoral response that is undertaken. And all these, the nerve center for all these responses is the PHEOC at the National Center for Disease Control, the Public Health Emergency Operations Center, which is now being linked to all the EOCs at the state level and HEOCs that are being established by Disaster Management Cell of Ministry of Health and Family Welfare. So this is a slightly repetitive slide. I won't go into the detail into this. So I will just telling you where the data is coming from. So it is coming from the field and the community level, and basically the hub of activity for us is the district. So basically everything is monitored at the district surveillance unit's dashboard, and the responses of course can be at different level from the state, district, state, and national level itself. And the response we have indicated already at the RRTs and the NGORTs. So these are the major stakeholders for One Health. So we have the lead agency is usually the Ministry of Health and Family Welfare. Then we have the ICMR, DSD, Wildlife Institute, FSSAI, and National Institute of Disaster Management. So as we know that in any disaster, be it earthquake, any major flood, or any kind of major natural disaster that happens, after that, usually we have some kind of outbreak. Usually they are foodborne outbreaks. Sometimes you will find that the cases of vector-borne diseases like malaria and dengue, they spike up because there is waterlogging. There is the infrastructure is basically damaged, and the public health system is also in the it is basically dispersed. So the PSC may be destroyed, or it may be submerged in water. So these are the basically here we have basically initiated the public health emergency disaster management in coordination with National Institute of Disaster Management to make sure that we are ready for that post disaster situation. So our field functionaries have the required training to act in the disaster and post disaster situations. So this is regarding the capacity building that we have from the facility level all the way up to the national level. So we have made a lot of emphasis on building capacity of the medical officers, field level functionaries, including ANMs, to basically help in the outbreak control and finding of any kind of event that is to be published into the system. Then we have talked about Vishanu Vyas, mock drills, and the PhDM program, which are the major simulation exercises and the mock drills that we undertake. This is the last slide I have, and I think I have run out of time also. So these are the key takeaways regarding the IDSP program. And thank you very much. And I will be glad to take any questions in the panel discussions.
Thank you, Dr. Varma, for that very interesting talk, highlighting especially the media surveillance as well as the importance of multidisciplinary action. Now I'd like to welcome Ms. Ranjini Mukherjee, sorry. Ms. Mukherjee is the Director for Research Knowledge Management and Capacity Development Coalition for Disaster Resilient Infrastructure. With over 20 years in disaster risk reduction, including roles with UNDP and the UN Office for Disaster Risk Reduction, her work ensures infrastructure survives shocks from hospitals during earthquakes to health systems during pandemics. Welcome, Ms. Ranjini.
Good morning, everyone. At the outset, let me thank Access Health International for inviting CDRI to the Global Learning Collaborative for Health System Resilience in 2026. We also had the privilege to attend this very important conference in 2025 as well as in 2024. Access Health International is a strong partner of CDRI, and it's a privilege for us to attend this very important and powerful convening that is happening in Delhi for the next 2 days. For those of you who are not much aware of what CDRI is the Coalition for Disaster Resilient Infrastructure. It's an international organization. It's a coalition of countries, UN agencies, multilateral development banks, private sector, and academic institution. We work towards accelerating the agenda of resilient infrastructure. It includes 53 countries and 12 organizations. We were set up at 2019 under the leadership of the Prime Minister of India. Our governance structure involves India is the permanent co-chair, and we also have a rotating co-chair. Currently, it is France, and very soon, Government of Brazil will be the rotating co-chair of CDRI. Before getting into my presentation, which typically I have divided into 3 parts. First, to provide a compelling narrative on why we are working on resilient health infrastructure. I'm standing in midst of a crowd where everybody comes with huge expertise in the field of public health. We work in the field of disaster risk reduction and infrastructure resilience, but we strongly believe that a country cannot have economic resilience or disaster resilience if it does not invest on building the resilience of its health system. And so that's why it's no longer building resilience of health infrastructure is no longer a peripheral concern. It is central to safeguard lives, sustain economies, and ensuring continuity of essential services. This particular slide, we have tried to kind of capture some of the disasters that are impacting health systems. And this is just highlighting some of the incidents, be it the California fire or the Hurricane Beryl, which hit the Caribbean, or the Turkey earthquake, the Nepal earthquake, the big disasters which Japan almost faces, every year, and the cyclone in Madagascar, Malawi, Mozambique in 2023, and again the Australian fire. So what the point I want to make here is the health infrastructure get impacted by multiple disasters across different geographies. And these disasters not only impact the hospital structure, it impacts the hospital operation, and it also impacts the lives of the community that depends on the hospital for critical emergency health needs. Now, coming to some of the statistics, according to a World Bank estimates, by 2050, climate-driven health effects are projected to generate 12.5 trillion of economic losses and more than 14.5 million excess death globally. Similarly, at CDRI, we have come up with a probabilistic tool which try to look at how different hazards impact 9 different infrastructure sectors. So we look at both the past hazards, but also on the impact of climate change. So it's a bit futuristic. And then what we do, we try to convert the impact into financial metric. And if I go by that metric, it is estimated that globally more than 700 million USD will be lost due to impact of 6 different hazards on the health infrastructure. And 65% of this loss will be occurring due to floods, followed by cyclone and earthquake. So this Giri data platform is open available in public domain. And if you're interested, you can visit CDRI's website and you can go there. And what it actually provides is country-wise average annual loss, which is essentially the risk embedded in various infrastructure sectors, including health. And so that every country gets an estimation of how much average annual loss the country might face due to impact of disasters on its various infrastructure sector. At the same time, as I mentioned, that we work on building resilience of infrastructure. So we have been talking about a framework for building resilience of infrastructure. And we typically look at 3 capacities: the capacity to absorb, the capacity to respond, and the capacity to recover. And shorter the period for capacity to, absorb, the capacity to respond, and the capacity to recover, that is what you known as the resilience dividend. So you invest on your capacity to absorb, you invest on your capacity to respond, and you invest on your capacity to recover faster. And that is the resilience dividend you gain. In the morning, we kept on hearing from from the various dignitaries who were there at the inaugural session that economic resilience cannot be achieved if we don't invest on health sector resilience. Further, to elaborate this concept for the health sector, we have also come up with a resilient health infrastructure framework, which I would refer to a little later. And this framework we actually developed with active support from WHO India. We have already piloted it in one of the hill states in India, in Sikkim. And based on that learnings from that resilient health infrastructure framework, we have been working with many other countries who are member of the coalition, trying to kind of, test that framework in different geographies, in different contexts, because the framework remains evolving and the framework gets enriched as we gain more evidence, more practical experience from ground across different geographies, which are impacted by different kind of hazards. I already touched upon these figures. It is $715 million globally as per CDRI's Giri model. And this is the impact only on the health infrastructure. If I want to kind of look at the overall impact of various disasters on 9 critical infrastructure sector globally, the figure ranges somewhere between 732 to 845 billion annually. Now, coming to the impact of disasters on health infrastructure. And since morning, we have seen that how a disaster impact the health system. Of course, there will be challenges on the public health. People will get injured, vaccination will be missed, hospitals will be overwhelmed, So one is the public health, how people will be directly impacted because there is a disaster and the health infrastructure is getting impacted. We also heard about hospital operations, emergency departments getting overwhelmed, surge of patient, disruption of routine services, and so on and so forth. And then comes the health infrastructure, which is essentially the damaged asset, the temporary facilities, and the disruption of the other critical services on which the hospital depends, which essentially means the power supply to the hospital, the water supply to the hospital, the wastewater management in the hospital, the telecom services available to the hospitals. At CDRI, we focus on building resilience of the health infrastructure because we understand there is a lot has been already done. Of course, there is a lot more to do, but there are very active global partners who have made tremendous contribution when it comes to public health management during emergency or when it comes to hospital operations. That is why what CDRI does, the value addition that CDRI is trying to do in this particular domain is building the resilience of the health infrastructure, and not only of the hospital building, but of the other critical infrastructure services on which the hospital depends. We already refer to all the existing frameworks and tools when we started working towards our resilient health infrastructure framework. And both WHO, PAHO are active partners of CDRI, and we work very closely with them. So we are not starting anything from scratch, but we are building upon the huge body of knowledge, tools, and practices that exist globally across different geographies and regions. With that knowledge, we came up with a framework for building resilient health infrastructure. And as I mentioned, our framework focuses on three things. It looks at the hospital building, it looks at the hospital operation, and it looks at the system view of critical infrastructure services. So while developing this particular framework, we have tried to integrate the existing knowledge to focus on infrastructure components. We have tried to unpack dependence of hospitals on critical infrastructure services by bringing in the systemic lens. We have tried to look at how explicitly the roles and the roles of the different health sector professionals and infrastructural professionals could be delegated so that they can work together and there can be a very systematic coordination between the various actors who play a very important role, particularly when there is a disaster and when people are affected and when there is a huge demand for health services at various levels. Finally, we also look at the asset life cycle for building and the maintenance. We emphasize on capacity building of the infrastructure professionals, and we try to influence risk-informed policy, investment, and planning. Again, in the morning, we heard about that we cannot talk about health system resilience if we don't have finances. And when we talk about finances, it is about having sustained investment and also to incorporate strategies in the public financial management framework and the policies. Because you cannot have sustained investment unless your policy actually outlines the need for such investment, and then it further gets integrated into the financial, management framework that exists at national and subnational level. So how CDRI is rolling out this framework? And as I said, this framework we developed with technical support from WHO India. It is still evolving because we are testing this framework. We first tested this framework in Sikkim, a hill state in India. There were rich learnings which emerged from that implementation process. And now we are trying to kind of take this framework across different geographies. At some places, we are able to kind of test a part of it. At some places, we are able to test whole of it. But the whole idea is we test it, we build evidence, and we keep on refining and, this whole framework. So the countries where we are currently working, we have 5 countries where we are actively engaged. We work a lot with the small island nations. As I said, we are an international organization. We have a flagship program, we call it IRIS, through which we provide technical support to the island nations. We have a project in Haiti. We have a project in Honduras. We are working with Marshall Islands, and we also worked in Nepal. Our first project, of course, was in India. Starting with the Sikkim. So we started our first pilot in Sikkim. We started our work sometime in 2022. And then after that, Sikkim was hit by a major GLOF-induced flood. I'm sure many of you must be aware of that in 2023, which brought in more traction to this important work. And there was incredible amount of support that we received from the government of Sikkim. They have done an exemplary work, I must say, because both the State Disaster Management Authority in Sikkim as well as the Health Department of Sikkim actually have won national awards by demonstrating, on-ground activities with respect to building resilience of health infrastructure. So it's not all paperwork, but it was real work that the government did on ground. So what we did under this project, this is a very dense slide, but if I may have to sum up, there were 6 things that we did in Sikkim. We developed a model hospital disaster management plan. So that was the first thing we did. We helped the government, we built the capacity of the government to understand what are the essential components of a plan, and then we help them to prepare that plan. So that was the first thing we did. What we also realized while working on infrastructure resilience, that building health sector resilience is not the job of only the health department. It required multi-sectoral coordination, and it requires a whole of government approach. So Sikkim was the place where we kind of test this whole approach, which we keep on talking about. We brought in the officials from the various infrastructure department, we brought in the officials of health department, and we brought in the officials of disaster risk management department, which is essentially the SSDMA and the revenue department together, and build their capacity on this model hospital DM plan. We also, as a part of the capacity building, train them on how to do a rapid hospital safety assessment. Because as I said, that a hospital, to keep the hospital functional and also to ensure that the delivery of the various services are there when after a disaster strike, the hospital, it is not only the health department can do that. Health department would require support from the Department of Power, the department responsible for water supply, the telecom services need to be active. For all that, there need to be a huge coordination across different departments and across different levels. So that's this whole of society and whole of government approach, which we often read across various reports, papers, publications. We try to test that on ground in Sikkim. We also supported the government to conduct a mock drill to test the level of preparedness and the preparedness of not only the health department, but the preparedness of all the other relevant infrastructure department. Thereafter, we also helped the government to come up with a roadmap for building the resilience of infrastructure resilience of Sikkim, particularly with a focusing on health. We also supported the government because we started this work even before the GLOF 2023 happened. However, when the GLOF happened, the initial orientation that we conducted, most of the officials found that very useful. So we also supported the government to do a very detailed post-disaster damage and need assessment. The PDNA report that Sikkim government prepared was developed to the submitted to the national government, and now Sikkim government has received the allocation from the national government to implement the recovery program. And finally, we also help government to identify sources of funding that are available to invest on resilience. Because one thing is, of course, advocating and talking about resilience and implementing pilots, but to sustain those pilots, you need financing. And what we did, we helped the government to map out the various sources from which they can pull in resources to invest on resilience for building resilience of the health infrastructure. We also did a piece of work in Nepal. We again helped the Nepal government to do a hospital safety assessment. We did this in collaboration with WHO CRO and UN Habitat and also the WHO Nepal office. We organized capacity development workshop on the hospital safety assessment. Then we supported to do that assessment in 7 hospitals across various provinces. Even the assessment used the WHO's hospital safety index, but it was further customized to include the accessibility and fire safety related assessment work. So that's how the customization happened. The tool included accessibility, audit, and fire safety elements. And currently, this is being submitted to the government. And all hospitals, in addition, were sensitized on disaster management and the importance of building resilience of health infrastructure. And we are in the process of these. We are hopeful that these assessment findings will provide input to the national policy and guidelines. Similarly, in Marshall Island, which is a very small atoll nation, highly vulnerable to cyclone drought, coastal flooding, we are working there. We are helping the government to conduct resilience of coastal and health infrastructure. So essentially the gap assessment, then to help them to come up with a roadmap to support data-driven resilience planning and investment. And we are also helping the government to strengthen its coordination with various national institutions and development partners. Just to, as a part of our flagship global research, we did a survey with more than 3,000 infrastructure professionals across the world. And what we see that the public sector's capacity, particularly in the small island nations, is very limited. This program, under the IRIS program, this small project in Marshall Island is actually helping in a big way to build the capacity of the government there to build resilience of their health infrastructure. The Haiti, again, another island nation, very vulnerable to disasters. Here we are actually working to build their capacity to respond effectively after a disaster. So the framework which I talked about in the very beginning, the capacity to absorb, the capacity to respond, and the capacity to recover. In Haiti, again, we are supporting the government to assess the health facilities, develop an action plan for improving backup system for resilience, and also kind of align Haiti's health policies and global standards to enhance their staff capacity to maintain operational resilience. Now, in all these small island nations, we have our implementing partners. In Haiti, we are doing it in collaboration with Geohazard International. In Marshall Island, we are doing it in collaboration with UNOPS. Whereas in India, as I mentioned earlier, CDRI and WHO India worked very closely to implement the Sikkim project. Finally, I know I maybe one more minute. We are also working in Honduras. Here, we are actually looking at the entire life cycle of the infrastructure. So again, vulnerability assessment of the primary healthcare. In the morning, we heard the importance of the primary healthcare facilities. So here we are supporting the Honduras to do this assessment and then helping them to create a digital technical assistance platform through which they can guide the municipalities and health authorities in climate resilient design, operation, and maintenance. This is about some of the impact. We have a roadmap in place. This is more from the Sikkim because other projects are still under implementation. But as I mentioned, the detailed work that Sikkim government did actually has resulted in national awards. The health department and the SSDMA both have been awarded by the national government. And today's Sikkim model is kind of being referred by many other state governments, particularly the hill states in India, to build resilience of their health infrastructure. As a way forward, CDRI will continue work with WHO, PAHO, and Access Health International and other global actors to promote RHI through capacity development, risk and resilience assessment, technical assistance directly to countries, and influencing policy and governance. In my closing remarks, I would like to mention that economic resilience cannot be achieved if we don't build the resilience of the health system, and we cannot achieve DRR, which is disaster risk reduction, if we don't invest on disaster resilient infrastructure. Thank you for for this opportunity and for your patience here. Thank you.
Thank you, Ms. Mukherjee. That was really enlightening to hear a slightly different aspect of preparedness, recovery, and response as well. Rounding out the presentations for today, for this session is Prof. Utpal Tatu. Prof. Tatu is the chairman, Department of Biochemistry, Indian Institute of Science. He was practicing One Health long before it became a global watchword. His laboratory works on neglected diseases, antimicrobial resistance, and zoonotic infections at the intersection of human, animal, and environmental health. He's a pioneer in making cutting-edge science speak to real-world public health challenges. Welcome, Prof. Tatu.
Thank you. Okay. Good afternoon. Good afternoon. What a pleasure for me to be here. Thank you, Dr. Krishna Reddy, for organizing this fantastic treat of global health focused workshop conference. It's been a pleasure listening to some of the stalwarts. Thank you, Dr. Rakesh Mishra, for leading from the front and showing this fantastic example of what can happen, what's possible to do at national level. And the team of Access who've done this wonderful logistics and organization. Such a pleasure for me to be here today, and I'm going to talk to you about my efforts in One Health. Oftentimes we think that you need to be in the government, you need to be in an organization, you need to be in a system, head of an organization to be able to make a difference. I'm coming from an institution in which I'm a small researcher. So the example that I'm going to show you is that, yes, as an individual level, you can make a difference. You can at least make an effort to make a difference. And that's really what my pitch is going to be. Of course, India is a very large country, so no amount of government support, no amount of organizations like CDRI and many others that we talked about will be enough. We really need more than what's possible. And that's really what I thought 15 years ago, that what can we do to contribute to this increasing public health issues in our country. And you'll see that I'm not sure how my presentation, actually, it had a PPT. It had a PPT first, and then yeah, it really had a PPT. And is there a PPT? This comes later. This comes later, actually. There was a PPT which started, and then there was a link to this. Okay, great. There we are, I think. So as I said, what can we do? Individual, there just isn't enough mechanisms and machineries available in our country to fulfill the need, to fulfill the challenges, to bridge the gap. As a researcher at Indian Institute of Science, I've been making small efforts, and I think it's working. The work that I'm going to show you very briefly, without going into too many details and data, is really give you probably a big picture and making you believe that, hey, you can do it. If you're a researcher anywhere, if you have a lab, you can probably contribute to this growing need of global level interventions that we are all trying to do. So, of course, my journey started, as Dr. Stuti mentioned, in 2013. I was invited to give a TED Talk, and I gave a TED Talk on One Health. And I really had to try very hard in 12 years ago or 13 years ago to explain to people the interface between human, animals, and environment. And many things that I said were probably very limited because my own understanding was limited, not knowing what was to follow 5 or 6 years later. But over the years, then, I think I have learned about what really One Health is and have practiced this through my research laboratory at Indian Institute of Science. Yes, I have been studying many infectious diseases, but many which are at the interface of human and animals. To give you an example, rabies, of course, SARS-CoV-2, many of us have worked on it, and many neglected infections, which are oftentimes of protozoan origin, sometimes bacteria, and sometimes archaebacteria. So this, as a researcher, I realized that the work that I'm doing, the publications that I'm publishing, probably isn't reaching where it is needed the most. And that's why several years back, I decided that I want to make a transition. I want to make a transition to doing more community-oriented work. And without having the government mechanisms to work for me, what is it that I could do? And yes, I made this slide to fool myself that I've been doing, of course, research on neglected infectious diseases, of course, using technologies and training students and scientists. Antimicrobial resistance, of course, our network with veterinary doctors, with medical doctors, as a part of our research at Indian Institute of Science, helped us to identify many new strains of infectious diseases. To give you an example, we were the first lab to identify Candida auris, multi-drug resistant Candida auris, which has become a reference genome sequence internationally for C. auris MDR form. We were part of National Sewage Surveillance Initiative. Professor Rakesh Mishra described this beautifully, but we played a small role, really a tiny bit, through individual research lab that I am in. Animal disease surveillance, there is an organized, of course, effort happening at ICAR level, but there's a lot of unorganized animal industry. And that's the database that I created over the years. And then, of course, one likes to fool ourselves. We think that, can we predict future zoonosis? And in some ways, during COVID-19, I want to tell you that we were doing coronavirus detection in animals since 2015. It's a common infection, as many of you know now, in dogs, cats, cattle. And we were looking at coronavirus infections in animals since 2015. So it was relatively easy for us to pivot and make some contributions. And one of the things that we did, and thanks to Dr. Rakesh Mishra, who encouraged us at that time, is to develop a RT-PCR kit for COVID-19, which ICMR had kindly approved. So over the years, we are encouraging One Health movement internationally. internationally strategic India, Switzerland, Africa collaborations. We are representing South Asia in One Sustainable Health Foundation, which is coming out of Institute Paris in France, and then of course leadership building capacity and creating tools for this. The real point that I'm going to make in the next few minutes, and I will keep it to 12 minutes, is to tell you that what we need really, and this is what Dr. Krishna Reddy always emphasizes, ground level work. We can meet in conferences, we can do idea exchange, but at the end of the day, you really have to work at the ground level. And that's really the message that I'm going to show you. You really have to understand what's happening in the remote villages of India. And that's such a challenging task. You'll only realize when you start. You really have to work with, of course, the cattle industry in some ways, but also small-time farmers to understand when they bring to you the problems that they have. We do this, of course, effectively through animal health camps together with the state departments of animal husbandry, as well as various other mechanisms that are possible in our government, state, and central government setup. We also do agricultural, soil, air, water investigation, and then have exchange of ideas between different economies. As I said, Africa, India, but also countries like Switzerland come, and we have cultural as well as exchanges that help us understand how is One Health being practiced in this country. Can we really learn something from one another? I presented this idea last year at One Sustainable Health conference, and I want to show you a bit of what I do in the last couple of minutes that I have. Can we turn this on, please? And I'm going to wrap with that to tell you that we have sort of broken India down. As I said, India has more than 500,000 villages. How are we going to be able to reach there? We need to start somewhere. We have a population of 1.4 billion. We have several 100 million cows, cattle, in numbers that we can also only try to judge by census, but we will never be able to really understand what's actually going on in that remote part of India where the help is required, where we really need to reach out. And towards that, we have created this concept of a model village. We created a model village, which in some ways we think represents India, which has all these hallmarks in bits and pieces. It has this, it's a part of India in South where we do work in a model village which has, for example, a poultry farm, a piggery, a natural body of water which supplies water to the villagers, a community of villagers. There is a primary health center, there's a veterinary hospital. So government mechanisms, the panchayat has done whatever it can to put together a system. But of course, we have been working in silos. Primary health center will never talk to the veterinary center. The community will never be able to understand that there's what's going on, the abuse that they're doing to the body of water eventually gets back to them. And this is what we have tried to do, interconnections in pre-existing pillars that are already possible are there in these villages. And that's why we call it the One Health model village, where we interconnect AMR data, the contaminants of the sewage water that happens in the local body of water through which water is supplied to the community, connect that to the problems that community presents themselves to the primary health center, connect them to the problems that emanate out of small-time animal industry, which is under the surveillance of government mechanisms. Communicate that with unexpected problems due to vectors which are present in this community. So we have created pillars of all of these main, the foundation of what we think is One Health, including, of course, the use of pesticides and so on in agriculture. What's coming out as a small example that we started in a village is now spreading. Now we are expanding this village concept also to a village in Gujarat, a village in Maharashtra, and then a village in Goa. We have talked to, of course, the Directorate of Health in all of these states to replicate blueprint that we have created of what we can do by interconnecting existing systems that are available in the village setting. We have created a dashboard which actually eventually aims towards, of course, creating a digital twin. And that's early. The fingerprint of a digital twin of a village is already available, and that's something that I'm happy to work together. Today we had some stalwarts. Dr. Kobargade is back here, and we can do this in Kerala, we can do this in Gujarat, we can do this in Maharashtra. We create data of human health problems which It is actually available in primary health center, as many of you know, but we are not connecting to the animal health problems, which are also independently available. To simple example, there would be, of course, the rabies. We have the stray dog population, which is part of the environment. It is the cause of rabies in animals. It is also the cause of rabies in humans due to dog bites. And this is data, that fragmented data, that's to an extent available, but we are trying to organize this in a better way and to create direct connectivity with what is the direct relationship between stray dog population and number of rabies cases present in remote parts of India. I want to end actually, because I lost some time, and say that this data is available. I'm happy to share the link. It's an ongoing work, but in the end, this is most successful in a particular village, as I said, in south of India, where we are focusing now as one water project. We have one health, but one water project where we look at the body of water, the recycling that happens, how does that impact the quality of water? Sewage outlets that are there from the community, how does that impact the quality of water? And eventually, how this quality of water impacts animal health, animal husbandry, as well as human health, for which all the data is available in primary health center and veterinary center. I want to end this talk by showing you that there is science. Of course, I spent all my life, 30 years at IISc, and I'm still at IISc collecting data, publishing papers, but now this is the most exciting phase. I always say that what came out of my research, my research career, and I said, yes, some diagnostic kits, some drug target claims, and hopefully this journey will continue. But I think personally, this has been creating a sort of One Health ground level. One Health in practice is probably the most exciting thing that I'm doing towards the end of my career. We use all the sophisticated tools that are available in the laboratory of Institute of Science, but eventually bring it out in the community. And to an extent, we are already successful. I want to end by showing you that what started 5 years ago as a small village project, and I'm so happy that Dr. Krishna found time to visit this village. I unfortunately don't have, but he spent 2 full days understanding this, how this dynamic works. And this is now spreading. As I said, we are now taking few more villages in Karnataka, in Gujarat, in Maharashtra. These are early days discussions that are happening. But eventually we want to do this all over India, because really can't address problem at a national level, no matter what magnitude of government support we get. We really have to fragment this to a small village level. And this is the concept that I think is going to augment government's efforts in different states to make a problem. We are talking to universities in Nepal. I'm so eagerly waiting to talk to Dr. Ranjini, CDRI, to see how we can tie up with them, but also to tell you that universities in Nepal are trying to create similar systems in villages in Nepal. Friendship Foundation in Bangladesh has shaken hands with us to do this, and eventually we want to go to Uganda, where Makerere University has shown interest in doing this. With this, I want to say that while this is a very satisfying effort, but also culturally very, very sort of fulfilling to be able to understand how One Health, global health, planetary health is perceived by different parts of the world. And with that, I want to thank again the organizers for this wonderful opportunity to make a small presentation. Thank you so much.
Thank you, Prof. Tatu, for being a shining example of converting evidence to action. Unfortunately, due to time constraints, we will not be able to go ahead with the panel discussion for this session today. Nobody is more disappointed than me that we cannot continue this conversation. For as long as our speakers are around, please feel free to engage with them if you have any burning questions. But with that, I would like to thank all of our speakers for making time with us for us today for a very engaging and interactive session. Thank you very much.
Thank you, Rohini, and all the distinguished speakers who joined us on this panel. All of you gave us a vivid picture of what the architecture of pandemic preparedness truly looks like.